of behave yourself.
Yeah, Shilpa madam.
Yeah, good evening, everyone. So today's topic is how to diagnose bowel endometriosis. So we have chosen this topic to speak about today because we are seeing so much of endometriosis where there is bowel involvement, and majority of it happens when the primary consultant has put in a scope and then abandoned the procedure and sent it over to me to get it operated by Dr. Jay. Or even in my fertility practice, whenever I have put a scope, I mean, I have found at least in 10 to 20% of cases, in spite of uh, doing investigations thoroughly, we are still missing out on bowel endometriosis. And we get a lot of queries on our various groups, at least like once in 2 days, about how to actually not miss bowel endometriosis, because as general practitioners and gynecologists, we understand that the skill sets required to deal with such a case during operative surgeries is extremely tough, and it becomes very difficult to counsel the patient that it is not operable by us, or that she will need another surgery to clear her disease, and also to do suboptimal clearance of the disease. So today's topic will only focus on like what a general gynecologist in her OPD should actually be looking for to not miss out on a endometriosis where there is bowel involvement. So since Dr. Jay is dealing a lot of cases with multi-compartment endometriosis, and his specialty being bowel resection and anastomosis, which I think he must have the largest series in the country now. And I have seen it happen so many times in our OT, where we have now counseling for every patient, even if it is a 3 centimeter cyst. We tell them that if he is operating, she may have bowel endometriosis, because sometimes we are unable to get to the diagnosis in spite of having multiple MRI reports and multiple scans. So today's topic will be very relevant for general gynecologists and laparoscopic surgeons too.
So I think, thank you, Shilpa madam. I think we would like to divide this topic for practical purposes into two parts. Okay. The part one for 5 to 6 minutes is going to be focusing on simply clinical examination history taking. And the part two of this is going to be focusing on basic radiological understanding of ultrasound and MRI. All right. I am going to be doing a screen sharing. Guys, I am traveling in a car and I'm going to be doing a screen sharing. So I request Shilpa madam to be unmuted so that I know if my screen is visible at all points in time. Okay. Shilpa madam, I hope you can see the screen.
Yeah.
Okay. So, see, I was just drawing this discoid excision today. That is because I was explaining this to somebody. All right. And this is exactly the type of diagrammatic representation we require in order for us to diagnose all this endometriosis very nicely. So what I'm going to draw is the posterior vagina and the anterior vagina. I'm going to be drawing the cervix and the uterus, and I'm going to be drawing the rectum. This is a little magnified view. All right. I hope, Shilpa madam, this is visible, right? So
Yes.
when we try to talk about endometriosis, all right, what are we trying to talk? First thing first, understand that there is something called as pouch of Douglas, correct? We all know this. It is the posterior peritoneum. Sometimes there is going to be in deep endometriosis an endometriotic deposit here in the pouch of Douglas and the uterosacral ligament complex. So pouch of Douglas and uterosacral is the primary deposition. All right. From here, it is going to go and invade in the bowel. So what does the bowel consist of? The bowel consists of an outer layer, which is considered to be the serosa. Correct? Inside the serosa is a second layer, which is a circularis muscle. Inside the circularis muscle, which is going to extend downwards, there is a layer of submucosa. Correct? And inside the submucosa, there is going to be the bowel mucosa. Now, what do we study in our textbooks? We study just one word, and that is dyschezia. Correct? We study this word, dyschezia. That means pain while passing stools, bleeding when she is having menses. That is going to happen clinically in a patient. If the patient is telling you, I'm going to show you the ultrasound for that today only, okay? Right now only. If the patient is telling you that I am having painful stool passage with passage of blood, that means she is a patient for bowel resection. Khatam. You don't even have to think of anything else, because for that to happen, this disease, I will draw the disease in black color now. The disease has to go right till the level of the mucosa. Only then she will start bleeding, isn't it? Till that time, she will not have any sort of bleeding. Okay. So a complaint which is much more common when there is pouch of Douglas endometriosis is going to be dyspareunia, especially deep dyspareunia, and vague pelvic pain. Okay, vague pain not related to menses. These are the two things which clinically, when the patient tells you, of course, you have to probe the woman for this. You will have to ask her, you will have to, pinpoint and tell that, boss, are you actually experiencing something like this or not? And if she says yes, then you are going to be understanding that, okay, there is some sort of a deposition somewhere in that part, even before you do the clinical examination. I would just like to draw and show you something else. I'll just delete this. I'll just delete this entire thing which I just right now drawed. All right. See, again, I will just tell you that this is the mucosa. All right. Above the mucosa, you have the submucosa, have the serosal layer of the bowel. If you have a bowel nodule which is just touching the serosal layer and invading inside the circularis muscle here, then the patient is not going to come to you and complain of dyschezia. Remember that thing. Okay, so when people try to talk, especially on a WhatsApp group, and continuously ask us the same question, why is it that you are saying bowel endometriosis when she is not having dyschezia? Are mere bhai, dyschezia is going to happen when there is so much invasion. Superficial invasion in the bowel does not give rise to this. This is starkly in contrast to a malignancy which starts from the fungating growth in the mucosa. So it is primarily a mucosal growth, and then it extends inside the outer layers. Endometriosis follows the exact reverse pattern. Okay. Now, after this, we come to the clinical examination on PV, especially in the posterior fornix here. You may find nodularity. Okay. And when you put your finger, gloved finger here inside the rectum, when your finger goes inside the rectum, first of all, your finger has to be around 9 to 10 centimeters in length. Your index finger. If you have a 5 centimeter index finger when you are using a glove size of 5, okay, your finger will not reach through that level of the pouch of Douglas, because the posterior vagina is going to be approximately 11 centimeter in length. So you need something at around 10 to 11 centimeters in length. Okay, and the nodule which is present till there, only that time it will be palpable. Okay. Otherwise, if the nodule is placed 12 centimeter, 13 centimeter, 14 centimeter, 15 centimeter above the anal verge, you will not be able to palpate that nodule. On top of it, since it is a procedure which is done without any form of anesthesia, it becomes extremely, extremely difficult for a woman to cooperate, and it becomes a painful procedure. But definitely, your per vaginal examination and your per rectal examination are very, very important. They are absolutely important when it comes to diagnosing this. Okay. One more thing as a clinical point. If a lady is having a Shilpa madam mentioned this. If a lady is having a unilateral endometriotic cyst, the chances of having a bowel nodule is going to be approximately 65%. That is deep endometriosis. If a lady is having bilateral nodule, then the probability that she has this type of endometriosis, deep endometriosis, close to 95%. Okay. With this, I am playing you a small ultrasound clip. You can see that this is how a normal uterus would look like. Everything is appearing to be so normal. And we will say normal ovary, normal uterus, everything fine. Patient has had 3 children. She cannot have endometriosis because it is a disease in infertile women. But there comes a large bowel nodule. Can you see that? This is a huge hypoechoic black colored bowel nodule on ultrasound stuck to that ovary. It is not an ovarian endometriosis. It is a massive bowel nodule. As you can see, this bowel nodule is reaching right till the level of the mucosa. If I zoom a little bit here, I'm marking it with my pointer and showing you. Now I've zoomed it, and you will be able to see it is reaching right till the level of the mucosa. It is massive in size, around 3.5 centimeters, 3.6 centimeters. surgeon today because she was in treatment with a colorectal surgeon for bleeding PR. When they put in the colonoscope, they identified that, Arey Baba, this looks like endometriosis. And obviously, if something is suspicious of endometriosis, a sensible colorectal surgeon in our city of Mumbai will usually refer it to a endometriosis specialist like us for further management. And that is exactly what happened. We changed the plane into the axial plane. And in the axial plane, as you can see, she has more than 50% circumference involvement. This is a patient who is a clear-cut indication for a bowel resection, as I was just mentioning. And of course, she is going to undergo a bowel resection in this week. Okay. But when you try to talk this to a patient, as Shilpa madam has asked and mentioned, this identification on ultrasound is first going to require your suspicion in your brain. Okay. Forget understanding how the bowel nodule looks every day across our WhatsApp groups. Dr. Shilpa madam was right. She's saying that every day there will be a query how to identify a bowel nodule after having demonstrated it for more than 300 times. Okay. So first thing is your suspicion. Then you will identify the bowel nodule. If you just put a probe, I know, see, apart from me, everybody else is a very busy practitioner. I know people see 70, 80, 90, 100 patients in a day. We also have people like Shilpa madam who break records. Suspicion to identify the bowel nodule. If you do not have that suspicion, you will never identify a bowel nodule. That is one. Second, clinical examination is only going to be possible if you are adept at doing clinical examination. If you are seeing endometriosis, let's say 2 times in a month, and you are not very frequently, examining the bowel nodules, you may not be able to pick up, because so many times we ask Shilpa madam when we go, madam, is there any nodularity palpable? And the answer is we could not feel anything, because at that point in time, patient was in OPD. And in an OPD, it is very difficult for a patient to cooperate and allow such type of deep examination. Many a times you may palpate a nodule only when the patient is under anesthesia, where she is completely relaxed. Bowel is nicely prepared. Remember, in an OPD situation, the bowel preparation may or may not be adequate, and a hard stool may confuse to a nodule to a newcomer. Okay. Cutting it down and giving one-line answers how to suspect bowel endometriosis in your OPD practice. Kindly start thinking when patient is not complaining of bowel endometriosis. If you patient complains, why did you do a bowel me on a daily basis? If they see the nodule the way I see it, even they will do the same bowel resection. It will just be that after 5 years, they will realize in retrospect that the comment which was passed was start seeing available for all of you. I'm sure you will pick up more bowel endometriosis, because I think Dr. Shilpa madam will agree to the fact that after we have started doing so many surgeries in Bangalore, Chennai, Hyderabad, the diagnosis for bowel endometriosis at their units have gone up. Okay. And I don't think it has gone up because I have started to come there. I think it has gone up because they have started seeing bowel endometriosis so frequently that initially, where probably if it was getting missed out, now it is getting picked up, and then the patients are getting appropriately treated. Okay. So with that, I will stop and I'll ask Shilpa madam to ask questions if there are any.
Yeah. So a couple of things, like what is that one message that you would want to give to a laparoscopic surgeon who is not very well versed in dealing with bowel endometriosis? And if at all, if they put in a scope and see that there is bowel endometriosis, so what should be one precautions to, I mean, at that moment? We have had so many cases who have been referred to us from tier 2 cities where it is written that extensive bowel involvement seen, there is a bowel covering the fundus, the ovarian cyst and all that, and the patient has to undergo another surgery, or they would have come back again after 1 month, and then we have had to do another surgery because the pain is not reduced. So how do we reduce such incidences? I mean, in your, because I suppose that you see quite a lot. I mean, I'm seeing so many of them. Of course, you would be seeing many more.
See, ma'am, first thing, as I told you, it all begins from your OPD. So the first thing is that suspicion and diagnosis. But now let's assume, despite all of that, it has come to you in front, when you are a laparoscopic surgeon and you have identified a bowel nodule, right? The first thing, madam, then comes down to your competence and your infrastructure. If you think you are competent but infrastructure is not available, then probably in a medico-legal situation, you may want to refer to a specialist. If you think the infrastructure is available but competence is not available, then at least in your mind you should know that you are not competent enough, right? You can't. Bowel endometriosis is one place where you know you can't goof up, because one mistake will give rise to a fecal peritonitis or a bowel leak or something like that, right? And it is better that you refer to a higher center should you think you are not confident, or you get trained and you treat the disease in a holistic manner. You evaluate the patient like how people do, before they are operating any surgery, right? And then you put in your scope, rather than putting in a scope and then identifying and then just playing around with the patient, because that day is gone. I mean, those times are gone when you can simply tell a patient, oh, now this disease cannot be treated. People simply log on to any social media platform and they will have 20 sponsored ads and 5 genuine people doing it, right? So that those days are gone. So I think we must probably live up to the expectations of our patients when it comes to bowel endometriosis.
Yeah, yeah. And on an average, if you deal with 100 cases of bowel endometriosis where you have done resection anastomosis, what do you think is the recurrence in such cases? Like many people ask us, I mean, you have removed 10 centimeter of the bowel.
See, per se, bowel endometriosis will not have a recurrence, madam, because bowel endometriosis is a nodular disease, correct? Once the nodule has been taken out, no, majority of the times the recurrence is not going to happen. What recurrence actually happens is in the ovarian region, because there can be many small foci of endometriosis. Unless you knock out that entire ovary, that's a different story. Conservative approach for multifocal endometriosis probably gives rise to a higher recurrence. But once you operate bowel endometriosis completely, see, that is an important word. You should have a free margin. Small free margin is fine, but you should have a free margin surrounding the bowel. If you cut through the nodule halfway, you think you have done shaving, but you have shaved only half the nodule. In all these types of situations, there is no recurrence actually. There is majority of the times what we try to comment as a residual disease. And this residual disease may then require surgical correction in the future.
So do you think these bowel nodules will actually cause bowel constriction at some point? I mean, severe disease. Have you seen bowel constrictions?
We are demonstrating 2 to 3 bowel constrictions every month now, right?
Yeah.
And the reason why we are demonstrating it every month is because, see, there will be, remember, quite a lot of them are our past patients. Huh? They have consulted us 5 years back. That time I was only 32, poor and uneducated, right? And that time if I would say, oh, you will require bowel endometriosis surgery with bowel resection, there were 500 people who would say, this is nonsense. He any which ways does not operate on his own. Don't go to him and get operated. I will give you Dynogest, right? And people have taken Dynogest till a point that they've got a stricture, right? Now, after the stricture has happened, you can't give Lupride, no? Because stricture is a stricture. So in that situation, when a third party, like a colorectal surgeon, oncosurgeon, general surgeon, urologist, they refer that, Arey, nahi Baba, you go to him, he is only going to operate. Any which ways, nobody else will operate. Understanding? By that time, the patient will realize that probably he was looking dumb, but what he told 5 years ago was actually the truth, right? And now, I think because thankfully, all of our non-operative colleagues are also making such beautiful videos on endometriosis that people have realized that there is something called as endometriosis, okay? And you need to give it some attention. So the minute they decide to give it some attention, organically we show up. And once we show up organically, obviously the crowd profiling will be higher, madam.
Okay. How significant is the symptom of constipation in bowel endometriosis?
Bowel is a very resilient structure. Okay. See, if it is going to allow stools to pass through it, two times in a day in a normal situation, and these are formed stools. If it is allowing formed stools to pass, okay, apart from anus, rest everything is a low pressure zone. Understanding? So it can get significantly dilated, no? And when that is how paralytic ileus is. In paralytic ileus, how severe is the dilatation? Correct? And still nothing happens. So bowel has enough capacity, madam. There is no problem in that.
Okay. Yeah. Thank you. Thank you for taking time out or taking time in with your dislocated shoulder and on the way and all this circus that you are doing to take the class. So thank you very much. Thank you, Vismay, for supporting him from the back seat. Thank you.